Hello everyone and welcome to the new edition of Learning Pharmacology. Today's selected topic is Half-Life Revisited. Now solutions to the previous homework. Question 1 was what fluid will you take for estimation of the levels of cyclosporin and tacrolimus? Whole blood or plasma? For this purpose whole blood is taken because these two drugs are concentrated in RBC and the blood concentration is 50 times higher than plasma concentration. Second question is there any drug whose plasma clearance exceeds hepatic blood flow? Yes, there are many drugs. Propofol is one whose metabolism occurs in lungs also, so its clearance exceeds the hepatic blood flow. Question third, can aminoglycosides be used to assess renal function? Limited GFR. The answer is aminoglycosides are not metabolized or freely filtered, neither secreted nor reabsorbed. Aminoglycoside clearance reliably correlates with creatinine clearance and estimated GFR as measured by other formulae. Aminoglycosides can be used to estimate GFR, particularly when renal function is rapidly changing. Question 4. Any drug that exhibits saturable absorption kinetics. There are few drugs. Gabapentin, pregabalin. Their absorption occurs by a large amino acid transporter protein in the enterocytes and the process is saturable. Therefore, as dose is increased, bioavailability relatively changes, that is decreases. Other drugs are methotrexate. Question 5. A formula that reasonably estimates GFR in obese individuals. Obese individuals have larger body volume and volume a change in the volume of distribution. So two methods are done. One is the body surface area is adjusted by and second is ideal body weight is taken rather than actual body weight by using the formula as given below. Alternately, one can also use Salazar-Corcoran equation. So by these methods, the eGFR in elderly can be estimated provided it is more than 30 body surface area is more than 30 kg. Now we talk of half-life of a drug. As we all know, half-life is an important pharmacokinetic parameter related to drug distribution and elimination. It is estimated by administering doses of the drugs in early clinical stages to find out the approximate duration of action and time to achieve the steady state concentration. Now there are related terms are biological half-life, biological effect half-life, plasma half-life, and plasma half-life is commonly used because drug concentration can be estimated. Now plasma half-life is estimated after a single dose, after a steady state half-life, or as a terminal half-life of elimination. Plasma half-life is the time taken by the drug to achieve 50% of its concentration, and in calculation of this 50% assumptions are made. Usually drugs obey first order kinetics, volume of distribution clearance are unchanged, body is considered as a single compartment. When we take two compartment bimodal, then terminal half-life can be estimated. There are no drug-drug interactions and there is no auto-induction or inhibition. Now, drugs that obey zero order kinetics, half-life is not fixed and it goes on changing as the dose is changed. Half-life increases with increase in the dose, and the classical example is plasma half-life decay can be estimated by concentration time curve, and we will see that it takes for about 4 to 5 half-lives for complete elimination of the drug from the body. Although some drug in micro and small quantities would remain for pretty longer time. Now we also know by fifth half-life, 96.87% of the drug is eliminated and it is considered to be completely out of the body. In a similar token, drug accumulation occurs when repeated doses are given at half-lives and the steady state is achieved by 4 and at this steady state, when repeated doses are given, the drug would show 50% elimination and therefore the line would be horizontal. And this is called as steady state. Now half-life varies from drug to drug. It may be few seconds adenosine to few minutes nitroglycerin and small dobutamine, or it can be few hours, maybe less than 5 hours. But even among the same group of drugs, for example thiazides, hydrochlorothiazide is much longer half-life than the chlorthalidone has a longer half-life than hydrochlorothiazide. There are few drugs whose half-life goes in days and months. Monoclonal antibodies, amiodarone, clofazimine, dutasteride. Their half-life is over several months. Half-life, clearance and apparent volume of distribution are interrelated by a typical formula. Half-life is the 0.7 multiplied by volume of distribution divided by clearance. So the two factors which determine the half-life is change in the apparent volume of distribution and change in the clearance. Now steady state half-life reflects the decline of plasma concentration during a dosing interval at a steady state. Blood levels are stable during dosing interval. Terminal half-life, a decline in concentration upon stopping drug administration or after a single dose administration, and these two may vary with many drugs. For example, gentamicin steady state half-life is 2 to 3 hours, whereas terminal half-life is 50 hours because it shows accumulation in renal tissues. Indomethacin is another example, and few more examples will be discussed. One of them is bedaquiline, whose terminal half-life may be extended for up to 5 months. Now, context sensitivity in half-life. Propofol and other intravenous general anesthetics show this phenomena. That is, half-life is about 10 minutes when propofol infusion lasts for 3 hours, but the same drug will give a half-life of about 30 minutes for infusions if they last longer than 8 hours. Here the context is the total dose over a period of time. And this point is important because compared to thiopental context sensitivity, the context sensitive half-life of propofol is lower or short, and that means when the drug is stopped even after continuous IV infusion for longer time, the recovery would be quick with propofol compared to thiopental. Now, many drugs show two phases of elimination. Some show 3 phases of elimination. Now, by exponential decline with 2 half-lives, atropine, lidocaine, ethambutol, rifabutine and telbibudine. Now here there is a terminal half-life and distribution half-life or initial half-life. Triphasic decline with 3 half-lives. Ramipralate is an example where there is 3 half-lives exhibited, 3-phasic elimination is there, and terminal half-life is longer. Methotrexate also shows a triphasic half-life of elimination, and terminal half-life is prolonged in renal. Half-life varies with the dose and route of administration. This point was discussed. Some other examples are aspirin, heparin, phenytoin, ethanol. Half-life varies with the route of administration. Clonidine, oral versus modified formula TTS. there will be long sojourn, so there is a long half-life. Aspirin doses up to 650 milligram, half-life is 3 hours. When dose is increased to 2 grams, half-life is 9 hours. Heparin is another example because at doses 100 units, 400 units or 800 units per kg, heparin when injected intravenously, it will show half-life of about 1 hour, 2.5 hours and 5 hours. This is because it is degraded primarily by RE system and small amount of the intact appear in the urine. Therefore, the terminal part is much longer. Biological action half-life is also important to understand. Biological action or biological effect of some drug lasts longer than actual plasma concentration of this drug. And interestingly, biological effect or action can be measured easily: pulse rate, blood pressure, PT, INR. So there are drugs which we will discuss which have a longer effect as compared to their half-life. And long half-lives of the drugs are correlated with larger volume of distribution and smaller clearance values. The ratio of Vd upon clearance. Clofazimine, bedaquiline, chloroquine, amiodarone, rifabutin are few drugs which are either highly lipophilic or cationic amphiphilic drugs. So they are lipophilicity that determines volume of distribution, and amazingly it is in excess of 100 liters in a 7 kg individual, and the distribution is both in central and peripheral compartment. Drugs may have a short half-life, but they have longer duration of action because of pharmacodynamic or pharmacokinetic reasons, and the examples are omeprazole, and the reason is pharmacodynamic, that is irreversible inactivation of hydrogen potassium pump or a proton pump. Vildagliptin, hydrochlorothiazide, valsartan, propranolol, heparin and low molecular weight heparin, clopidogrel, aspirin, glimepiride, all have a reason that their duration of action is longer than the half-life. For example, glimepiride has a half-life of about 3.5 hours when initiated, but increases to 9 hours on repeated dosing. Yet it is given once daily because there is slow dissociation from the SUR pump on the beta cells by its metabolite. Another example is valsartan, whose half-life is 6 to 9 hours only, but it has insurmountable antagonism at AT1 receptors. So sustained AT1 blockade is seen, and the effect lasts for about 24 hours. Vildagliptin also shows slow dissociation from inhibited DPP4 enzyme. Hydrochlorothiazide is a glaring oldest example with very short half-life but a longer duration of anti-hypertensive action because the drug induces gradual reduction in the peripheral vascular resistance. Half-life may be less relevant when drug obeys zero-order kinetics or the drug is a hit-and-run drug, monoamine oxidase inhibitor, a suicidal irreversible inhibitor, and for antibiotic, half-life is important, but more important is the pharmacokinetic, pharmacodynamic mechanism. That is the area under MIC ratio. That will tell how effective the drug is. Therefore, it is always MIC, MBC levels which are estimated for finding out the efficacy of antimicrobial as concentration dependent or time dependent killer. Half-life changes of a drug due to autoinduction or autoinhibition on repeated doses. Carbamazepine, phenytoin, nevirapine, efavirenz, ritonavir, rifampicin. They all show auto-induction, so a decline in half-life on continuous use. For phenytoin, one must understand that because of saturation elimination, this effect is more important than auto-induced decline in consumption. Auto-inhibition may also occur with some drugs: clarithromycin, fluoxetine, verapamil, voriconazole, and its metabolites. Usefulness of half-life. Knowing all this is important because half-life provides information about the time to achieve a steady state rate of elimination and type of the elimination of a drug. So it gives a rough idea of the duration of action. It also gives rough guide for dosing interval, but there are many drugs that will have longer duration than expected from the half-life. Determining the loading dose for the drugs which have very short half-lives to achieve a sustained plasma level in serious conditions, for example, lidocaine to terminate ventricular arrhythmias. It is also true for drugs with longer half-lives, so amiodarone and chloroquine. Chloroquine oral loading dose is given for treatment of acute chloroquine-sensitive falciparum malaria. Amiodarone has to be loaded to achieve the desired plasma levels in acute arrhythmia treatment arising from atria and ventricle. Drugs with long half-lives, if given frequently, then their short and then half-lives would tend to accumulate and cause toxicity. A change in the half-life denotes altered volume distribution or and clearance, and therefore indirectly it indicates a change in the organ function. It is a useful parameter to manage drug toxicity, particularly zero-order kinetics. And many neuropsychiatric drugs with short half-lives are associated with withdrawal syndrome. We know the difference between morphine versus methadone and buprenorphine. Summary points are: half-life is the time taken by plasma levels to decline by half, is a guide for dosing interval and achieve steady state by loading dose, and there are many factors that determine nature of drug: active metabolites, drug distribution, drug storage, plasma protein binding, tissue binding, enterohepatic recycling, and the type of elimination, first order versus zero order. Clearance of the drug also affects half-life, and the rate of release from different formulations also will change. Therefore, half-life is an important parameter. One may go deep into differences and find out more information. As a homework for all, but particularly for PG, is what is the difference between irreversible and suicidal inhibition of enzymes and receptor targets? Give suitable examples. It will be found in all standard textbooks and the other learning resources available online. Also visit the next episode for finding more. Thank you very much and good luck.